right, let's talk about something we as endocrinologists deal with all the time. It's that moment when a patient's biggest concern, low sexual desire, doesn't neatly fit into the hormonal box we're so used to. So we're going to dive into how to handle this incredibly common and often really complex clinical challenge. I mean, we've all been there, right? A patient walks in, they're upset, they're frustrated, and they're looking to us for a straightforward hormonal answer to their loss of libido. And just like that, you're standing right at the crossroads of what the patient hopes for and what the clinical reality actually is. And this isn't just a handful of patients. We're talking about almost half of all women in the US reporting some kind of sexual concern. And guess what the number one complaint is? Low desire. So this is way more than just a quality of life issue. It's a major public health concern that lands right in our exam rooms. Okay, so to really get a handle on this, we're going to use a clear step-by-step approach. We'll start with that patient sitting in front of us, then we'll look beyond hormones to the brain. After that, I'll lay out a really practical four-step framework, we'll go over the treatment options, and finally, we'll talk about defining our specific role in their care. So let's start with that first visit. The patient is absolutely convinced it's their hormones. And to be honest, a lot of our training pushes us in that direction too. But as we're about to see, just looking at this through a hormonal lens is, well, it's really limiting. And look, you don't have to take my word for it. The official guidelines from the International Society for the Study of Women's Sexual Health, the ISSWSH, are crystal clear on this. They flat out say that just checking a standard hormone panel is not the way to go. Why? Because study after study shows a really weak link between a woman's circulating hormone levels and how much desire she actually feels. And this really is the heart of the problem, isn't it? We run the labs, everything comes back in the normal range, and now we have to turn to a really distressed patient and say, well, everything looks fine. It's this total mismatch that just leads to a dead end of frustration, for them and for us. So, if it's not really about the hormones floating around in the bloodstream, where should we be looking? All the evidence is pointing away from the endocrine system and straight toward the central nervous system. The real action is happening in the brain. Probably the most helpful way to think about this is what's called the dual control model. So instead of thinking of desire as some kind of on-off switch, picture it more like a constant balancing act. It's the push and pull between signals in the brain that are hitting the gas and signals that are hitting the brakes. This is a fantastic analogy to use with your patients. The gas pedal is all about neurotransmitters like dopamine and norepinephrine, the things that fire up motivation and arousal. And the brake pedal? That's mostly serotonin, which is tied to feeling satisfied and inhibited. So low desire often isn't an empty gas tank. It's that the brakes are being slammed on too hard, or the gas isn't getting enough of a push. Or, a lot of the time, it's both. Okay, so we've got this new understanding of the neurobiology. That's great, but how do we actually turn that into something we can use in the clinic? This next part is all about a four-step framework you can literally start using tomorrow. First things first, a quick update on the terminology. The DSM-5 has actually merged the old diagnoses, hypoactive sexual desire disorder, or HSSD, with arousal disorder. The new combined diagnosis is called female sexual interest/arousal disorder, or FSIAD. And this change makes so much sense because it reflects what we see clinically. For a lot of women, desire and arousal are completely tangled up. One often sparks the other. So to officially diagnose FSIAD, a patient needs to have at least 3 of these 6 symptoms. They cover everything from interest in fantasies to actually initiating sex and feeling pleasure. And there are 2 really critical footnotes here. The symptoms have to be going on for at least 6 months, and, this is the big one, they have to be causing the patient real, clinically significant distress. Now, when it comes to structuring the conversation, the best tool I've found is the PLICIT model. It's a simple 4-step guide that takes you all the way from just opening the topic up to knowing when you need to refer out. It stands for permission, limited information, specific suggestions, and intensive therapy. Step 1 is all about giving permission. You can do this with really simple, normalizing scripts. You could see something like, many women with diabetes notice changes in their sexual desire. Has that been your experience at all? A simple question like that does 2 things. It gives the patient permission to talk about it, and it gives you permission to ask. It just takes the stigma right out of the conversation. Now, during that limited information step, one of the most powerful things you can share is the idea of responsive desire. So many women think desire is supposed to be this spontaneous lightning bolt out of the blue. When you explain that desire can also be responsive, that it can show up after arousal and pleasure starts, it can be a total aha moment.
It reframes their whole experience from feeling broken to feeling normal.
All right, once we've opened that door, made a diagnosis, and shared some of this key information, we can start talking about specific suggestions and treatment. And that includes both medications and non-medication approaches.
What's so interesting here is how these medications line up perfectly with that dual control model. Flibanserin, it works on serotonin pathways, the brakes. Bromolatide and bupropion, they work more on dopamine pathways, the gas pedal. For our postmenopausal patients, off-label transdermal testosterone is an option, but you have to monitor it carefully. And it is so important to remember that none of these are silver bullets. The effect is often pretty modest.
And that is exactly why just writing a prescription is rarely the full solution. We have to think biopsychosocial. You have to address all the other things that are slamming on the brakes, like stress, exhaustion, or problems in the relationship. That means things like mindfulness, CBT, and even just basic lifestyle improvements are often your most effective first moves. And that brings us to the final and maybe the most important piece of this whole puzzle, figuring out our role as endocrinologists and knowing when it's time to call in some backup. This is the intensive therapy part of our Plicit model. We have to be clear, we are not sex therapists or trauma counselors. If you start to uncover major relationship issues, a history of trauma, or serious mental health conditions, a referral isn't just a good idea, it's the standard of care. Our job is to spot these deeper issues and get the patient to the right specialist.
So, when you boil it all down, our biggest goal here is to manage expectations. We have to gently but clearly guide our patients away from searching for a simple hormonal fix and help them embrace a much more complete picture of their sexual health, one that gives them real knowledge and a plan with multiple angles.
So I'll just leave you with this final thought. When we make this one fundamental change in how we approach this, moving from that narrow hormonal view to a broad, brain-focused, biopsychosocial one, we're doing more than just solving a clinical problem. We're actually transforming our role from just a lab test gatekeeper to a true partner in our patients' overall health and well-being.